Welcome, Dr. Demir. And just a reminder for everyone that this recording is for educational purposes only, does not constitute medical advice, and we encourage you to talk to your own medical team about your own specific plan and treatment. So welcome, Dr. Demir. As you know, Dr. Demir is a surgical oncologist from Hoag Cancer Center Institute, and joining us from Newport Beach today. He is internationally recognized and well published and has been involved in the NET community and in NANETS for many years. Thank you for letting us know that this trial is open, and we're excited to hear more about it.
Yeah, thank you. Just a little background, I guess it's a lot of gray hairs, but did my endocrine surgery fellowship and finished in 1991. So yeah, I remember presenting some of our research at your Santa Fe meeting, which I think is one of the very early ones that I went to. So we were looking at the genomics of neuroendocrine tumors at that time. So yeah, it's a pleasure to see how this overall NANETS group and LACNETS has grown. And it's all really a tribute to the patients who supported our efforts. So anyway, we're really here to talk today about this clinical trial from Crinetics Pharmaceuticals. They have the first oral somatostatin receptor type 2 and agonist. It's called paltusotine, and it's once daily dosing. And it's basically, let's say, an oral agent, which the goal is to replace the monthly injections that you guys many of you would be getting with either lanreotide or octreotide LAR. Okay, so I'm just going to kind of go through things in general, and then happy to answer any questions. So in the preclinical development, it was done in acromegaly as well with a phase 3 trial, and we're interested in looking at it in carcinoid syndrome to compare symptoms primarily right now. Eventually, my understanding is that they'll look at it in terms of looking at tumor progression in a formal clinical trial, much like the PROMID study was done. So it's once daily dosing taken on an empty stomach. In general, in the acromegaly trial, it was well tolerated. The main side effects, headaches, arthralgia, some fatigue, but overall pretty well tried. Some people had abdominal discomfort and maybe diarrhea, but anyway, those are the main things. So generally well tolerated, with most of the side effects being in the grade 1 and 2, which we grade them on 1 to 5. So the more milder side effects. So the trial is really is a randomized parallel group study, open label, to look at the safety, pharmacokinetics, and dose response of paltusotine in patients with carcinoid syndrome. Okay, those symptomatic patients. They're looking to accrue about 30 patients overall, including some patients who are taking proton pump inhibitors at the time of screening. We are now open for the trial. I think there's one other site open, and I honestly don't know where that is. I think it's one on the East Coast, but and they're looking overall at 12 sites to open. So it is a trial in which you have to go off your monthly injection, and then you start on, so there'd be a washout period, and then you start on the oral agent. And the comparison is really comparing 40 milligrams to 80 milligrams for up to 8 weeks, and then there's a follow-on study, and the follow-on study may be also include doses up to 120 milligrams. So the screening period is usually over a 2 to 12 week period, and then there's 8 weeks on the randomized treatment, and then additional 50 weeks on the expansion. Basically, to be eligible, you can either be somatostatin receptor treatment, naive, you haven't been treated, or you could be stable on treatment with control of your symptoms. But if you're off your drug, you have 4 more bowel movements a day or more than 2 flushing episodes per day, at least 2 days over a period of 2 weeks. Have to have carcinoid tumor with elevated 5-HIAA on biochemical testing. As I said, agree to wash out from your monthly injection, which means you stop that treatment and let it clear your system. let's see what else. The main things they're looking at is safety. And also they want to get blood tests to look at drug levels. So that's what we call pharmacokinetics. So the primary endpoint is safety, which in terms of looking at side effects and all that. So there's going to be some blood tests, EKGs. There's patients on the higher dose would get a continuous cardiac monitor looking at EKGs. And they want to look at blood levels as well, blood tests. So then they also do want to look at tumor responses. That's a secondary aim in terms of tumor shrinkage. But the other objectives are to look at the efficacy in terms of frequency of bowel movements, episodes of flushing, effect on biochemical markers, how often you might need rescue with short-term octreotide injections. Let's see. So safety, tolerability we talked about. Secondary also is effect on potential tumor progression. So the key eligibility criteria to be in 18 years or over, willing to comply with the study, including the washout and the blood tests, and complete an electronic diary for a 2-week period, and then also document your symptoms. Have to have, as we talked about, the carcinoid syndrome, which is either the flushing or diarrhea, and requiring medical therapy, and at least in one elevated 5-HIA level. Let's see here, what else? Grade 1 or 2, well-differentiated neuroendocrine tumor. No evidence of significant disease progression, even why it could be why you're on somatostatin therapy, and have had a positive gallium or copper dotatate scan, or positive. I guess this. I don't know if anybody still uses them. At least we did the old somatostatin receptor scintigraphy. But if that was positive, that would be okay. If you're a woman, you have to be, willing to make sure that you don't have a baby. So the men should use a condom or some other acceptable birth control, vasectomy or whatever. Exclusion criteria would be that if you have other symptoms, other causes of diarrhea, dehydration, hypotension, severe uncontrolled diarrhea, in which you need things like Zermello for second-line therapy, so that would exclude you. If you've had recent, within 4 weeks, PRRT, embolization, or other tumor-specific therapy, you have to have what we call a good performance status. In other words, you're up and about, and you have, you're not bedridden kind of thing. You're up and about, and you're functional in terms of your performance status, we call, and a major surgery within 8 weeks prior to starting the study. Any other known cancers except, for example, superficial skin cancers. Let's see, diabetes. There's some exclusions regarding uncontrolled, poorly controlled diabetes, history of angina, or acute myocardial infarction within 12 weeks. Certain drugs that you can't take. Certain drugs you can't take. And I'm trying to think what else. Unable to, they said unable, I'm looking at my checklist, unable to use rescue octreotide if necessary. Hypersensitivity to any of the test materials or related compounds. There's some EKG things that, have to have, there's some EKG and lab abnormalities that would exclude you as well, but that's all part of the screening. So main thing to look and see, I guess, how well this oral agent may be a substitute for monthly shots. It's a daily pill instead.
Yeah, this is exciting, and thank you for opening it. If you have questions, go ahead and put them in the chat box. I do have a couple questions, Dr. Demir. You mentioned the washout period, so people have to stop their monthly injection to go on the study. How long does it need to be stopped?
I believe it is 6 weeks. I'm going to double check. It's either 4 to 6 weeks. But during that washout, you can use the short-term octreotide, is my understanding.
Okay. And during the trial, can people also use short-acting octreotide?
Yes, you can use that as rescue, but that's one of the things I'll keep track of, is how often you need to do that.
Okay. And you mentioned that there's, many weeks. There's screening for 2 to 12 weeks, and then 8 weeks of the dosing, and then
it's basically a year plus a few weeks study, or 58 weeks overall is your your time on study. There's sort of the active, and then there's which is, I believe, the 8 weeks, and then there's 50 weeks of sort of the phase 2 of the trial, if you will. It's not a phase 2 trial, but the second phase of the trial, in which it's more of a maintenance. So at that, they look at, I think you have a CAT scan around the beginning of that second part of the trial. And then at the very end, there's CAT scan as well.
Yeah. How often would the doctor's visits be required?
Let me see if I can look at the actual schedule. Typical for the studies, they're occurring more frequently in the beginning, and then they're spread out. Yeah, you can get some travel reimbursement. They have travel reimbursements in there too.
So while you're looking for that, what if someone has carcinoid syndrome, but the 5-HIAA test doesn't show?
Well, it has to have been elevated in the past. So I don't know that it has to be elevated right to be time of screening.
Okay.
I think they're trying to confirm that you have a functionally active tumor as far as enrolling. Any of those individual type things, we just have to kind of look, and then, we can try to advocate.
So with the elevated 5-HIAA, is that urine or blood?
Either, I believe.
Okay. And if someone doesn't have it necessarily showing up, but they do have symptoms, that's something that you said could be advocated.
I think we have to, those kind of individual exceptions, you have to go to the study monitor, and you have to see if they'll include that, if they'll agree.
Okay. And some people have no evidence of disease on scans. Would they still be eligible?
I think it said it had to have a positive scan, if that's what we went over before.
Yeah.
So let's see, it's every 2 weeks, and then you go on the second phase. It looks like it's every 12 weeks. Week 24, week 36, week 48, week 58. And then I think there's one final one at 4 weeks afterwards. And you get the CAT scans that, they do the PKs in there. They do some blood types and all that during that extension phase as well.
Okay. So it's every 2 weeks for the first 12 weeks, and then every 12 weeks?
Yeah, roughly. Yeah, for the first, at least the first 2 months. And then it's, then the intervals are spread out.
Okay.
So I think we talked about the inclusion. Just to clarify what you said, was I do believe you did have to have a positive scan.
So a positive scan recently?
I believe so. Yeah, you have to. Yeah. So here, let's see here. We did.
So someone was diagnosed, had positive dotatate, then they had surgery. Like you did surgery on them and did an amazing job and took out everything that you could see.
Yeah, well, then, I think but if you have symptoms from carcinoid, then, so the 5-HIA has to be plasma, has to be twice normal during screening for native patients that haven't been treated. They didn't quite, I don't think they specified what it had before. And I'm trying to see if the scan had to be positive at the time. I don't see it documented, but I would double check, but I think you have to have. I don't know that the scan needs to be positive at the time, but you do need to have disease. Let's see here. Have to have documented carcinoid syndrome requiring medical therapy, and at least one historical incidence of an elevated 5-AHA level, and that's for the people that are on treatment. If you're treatment naive with a somatostatin analog, you have to have a 5-HIA level at least twice normal during screening. I think the recognition is that the monthly shots could lower your 5-HIA levels. So I think people on medication are not actually being required to be treated.
Okay. And if people are coming to the center, this would be the Newport site?
We are open both so I see patients at Newport Beach, Hospital Hogue. It's right on Pacific Coast Highway in Newport Beach, right where 55 or Newport Boulevard's called. It's right there, right near the ocean. And we do have a Hogue Irvine campus. My colleague, Dr. Tara Siri, she's a medical oncologist who is interested in carcinoid at our center here. She sees patients at Irvine and at the Hogue Irvine campus, which is on the 405 South Orange. It's just south of John Wayne Airport. So the study is open there as well. So she could see you there if you chose, which for some patients, and I know you had Dr. Ulaner on 3-4 months ago, and we talked about our Center for Imaging and where people can get PRRT. That's done at the Irvine campus. There's a dedicated facility with 3 very nice treatment rooms specifically designed for giving, we call liquid radiation. As you may or may not know, it's a form of PRRT is called PSMA, is now approved for stage 4 prostate cancer. So all this is being done at the Hoag Irvine campus.
So one other question, looking ahead, if the trial does show efficacy, how many years do you think it might be when this treatment alternative might be at the approval stage?
Oh, it's going to be a long-term process. Now, I think the prospects of getting approval for symptom control, where and I think that's an easier, quicker study to do. But many of these tumors can be pretty dormant for a while. So to do the prospective trial on disease progression, if you will, is going to take a few years. So I think it's going to be a little while before it's approved as as tumor progression. But for people that have diarrhea and symptom control, I think that's something that could be done in the much more near term. But it's still going to be 3-4 years, I think, because this study is going to take probably 2 years to enroll and complete, right?
2
So
years.
we get all 30 patients on within a year, and then the trial is still going to take a year, and then there's going to be another year to probably for the study to get published, and then the FDA has got to review it, everything like that. So best case scenario is the oral agent won't be available for 3 years or probably a little longer. Best case scenario.
So you anticipate at least a couple years, 2 years maybe, or so.
For completing the study?
For seeing the results.
Oh, seeing the results might be closer to 3 years because, again, the data has to be analyzed, written up. It has to get submitted and published and all that.
Okay.
So I think realistically 3 years is probably, because it's going to be a best case scenario, but, all patients get enrolled within a year. And this is where the community can help, obviously, but then it's a 58-week trial, but then you have to get all those results and they have to analyze them and write them up, submit them to a journal, all that kind of stuff. And then after that, the FDA gets it and they may sit on it for a while, as with they did with PRRT, took a while. So
yeah, it's a labor of love, and it's an opportunity for us, in the community, as patients and advocates, to be part of the future and be part of changing that.
Well, maybe can I tell you about another little project that we have going on that, again, if anybody is interested, but
absolutely.
with patients with, we're starting to work with another company called Certus Oncology, but what they do is they take tumors and they grow them in mice. And so a patient has their own tumor growing in a mouse, or we call mouse avatar of their cancer. And we've now done 3 or 2. I have one more patient in the queue that's going to have surgery August 1 with a neuroendocrine tumor. And we're growing them in the mice with the idea that then you could treat the mouse to see what might work best for the patient in terms of drugs. Or see, for example, with pancreatic neuroendocrine tumors, we have, not only do we have Lutathera, but we have capecitabine temozolomide, everolimus, sunitinib as FDA-approved treatments. But there's no predictor of which one will be most effective. So we're trying to see if Dr. Mouse, if you will, can be a better predictor for the patient. So it's just a new trial, but if somebody's going to have a surgery or even a biopsy of their tumor, we could send a piece of it, and the company is growing them. They're going to do 50 for us without any charge to the patient or us, but they want to accumulate the data and show that they can get that. And the goal is, we've actually been talking to Dr. Herb Chen, who is, you may or may not know, but he's part of NANETS, but he's a chair of surgery at University of Alabama, and they're applying for a pancreatic neuroendocrine tumor spore grant, which is a kind of a NIH program project grant, and to focus on that, like the guys at Iowa have a spore in neuroendocrine. But so they're applying for that, and this mouse avatar is going to be, or at least we're talking to them, and we had some discussions. They're interested in including that as a developmental project within their pancreatic spore or pancreatic neuroendocrine tumor spore. So if anybody's, on the West Coast and needs to have, for whatever reason, tumors are progressing and they need to have a repeat biopsy, or there's, we've operated on some people, for example, in carcinoid tumors and causing bowel blockage, and we have to resect that. We've sent those tumors. We're sending a couple of those off now for growing in Dr. Mouse. And anyway, that's just that sort of opportunity to let you guys know something new that we're kind of excited about.
Yeah, that is exciting to, again, donate part of our cells, our tissue.
Yeah, otherwise it sits in a block and wax, and pathology is not doing anyone any good, right?
So if interested, if someone is having biopsy or tumor removed, how would they go about
just contact me. Now, the tumor has to be fresh, so it's not something you can have like a biopsy done in Bakersfield or wherever, and then, it has to be done, probably pretty much has to be done here, so we can collect the tumor fresh, put it in the appropriate media, and send it to the lab.
Okay. Well, thank you for sharing these opportunities.